Yeah, so thank you very much for the nice introduction. And in fact, what you can see here is a picture of Heidelberg in winter. And our objectives for today are just to quickly review the physiology and pathophysiology of PSMA. And then we are going to talk a little bit about the benefits and limitations of PSMA PET imaging. And last but not least, we are going to discuss the potential of PSMA radioligand therapy. Just to complete the picture, there are two things PSMA I'm not going to talk about today. One is PSMA antibodies, and the other one is PSMA SPECT imaging. So what is PSMA? PSMA is a type 2 transmembrane protein, and with that it has an intracellular portion and a transmembrane portion and an extracellular portion which actually has an active substrate recognition site. The whole thing is pretty much the same like the glutamate carboxypeptidase 2, which we have in astrocytes. And next to prostate cancer cells, we do know that PSMA is expressed in normal prostate epithelial cells, in the small intestine, in renal tubular cells, in the salivary glands, on astrocytes, and even so in some solid tumors, there it is expressed in the neovasculature, like for example colon, breast, renal, and bladder cancer. So once a ligand binds to this active substrate recognition site, it gets actually internalized via chlorine-coated pits, and that means that the imaging or the therapeutic agent really stays in the cancer cell. However, the function for prostate cells and for prostate cancer cells obviously is still not completely known. What we do know is that PSMA is overexpressed in nearly all prostatic cancer cells, 100 to 1,000-fold, and we do know that PSA expression increases progressively in higher graded tumors and the androgen deprivation in metastatic disease and in castration-resistant prostate cancer. And on my next few slides, I just want to give you some examples to underline what I just said. So this is a summary of the studies that looked at histopathologically at PSMA expression in prostate cancer. And in 84 to 100%, there really isn't PSMA expression. And on the left-hand side, you can see some corresponding staining to that. So that's immunohistochemistry staining. And you can see that in BPH, there's rarely an expression, especially compared to prostate cancer. And on the bottom, you can see the progressive expression with the Gleason score. So not that many in Gleason pattern 3, more in Gleason 4, and quite a lot in Gleason 5. What the authors of this study did is that they looked at radical prostatectomy specimen. So they looked at specimen from 136 men and performed some immunohistochemical staining. And what they found is that PSMA overexpression is not only correlated to the Gleason grade and the tumor stage, but even more significantly to biochemical recurrence. So patients who overexpressed PSMA were more likely to develop biochemical recurrence and develop that early on. This slide is just to demonstrate once again the physiological distribution. It's actually a scan from a healthy man who received one of the new fluorine-18 tracers. And what you can see is that after a few minutes, the blood pool activity is quite low. And as I already said before, you can see the physiological distribution in the salivary glands, in the renal tissue, and also a little bit in the small intestine. And then there is another interesting background work out there that looked actually at PSMA activity in under androgen deprivation. And what the authors of this study first did is that they looked at mice, tumor-bearing mice, who were treated with either an androgen inhibitor or orchiectomy or a vehicle. And they performed imaging before treatment and 7 days after treatment. And what they found is actually a 1.5 to 2-point-fold increase in the animals that were treated with androgen inhibitor or orchiectomy compared to the animals treated with vehicle, where there was no increase. They also basically performed the same thing in one patient with castration-sensitive prostate cancer. So they performed the scan 4 weeks before therapy and 4 weeks after therapy. And also in the patient, they saw a 7-fold increase of PSMA uptake. And actually, you can see the 4 weeks after scan here in picture B. And there are 22 lymph nodes on that picture, and 13 of them only showed up after androgen deprivation therapy. So as some have maybe expected, androgen deprivation therapy has really helped to visualize things on our PET scan.
Are you seeing salivary gland uptake there?
Yes, exactly. That's up here, so that's not a pathological uptake, and also around the eyes, that's physiological uptake. Yeah.
Can you tell us why?
Hmm?
Can you tell us why it goes up?
No, not yet.
Next year?
Maybe. So, yeah, to summarize that, PSMA is a type 2 transmembrane protein. It's overexpressed in prostate cancer cells. Expression increases with high-grade tumors under ADT in metastatic disease and in castration-resistant prostate cancer. And I guess that really explains why it's such an ideal target for diagnosis and therapy. So before we now move on to diagnosis and therapy, I want to give you a little bit background on the legal situation here. Because actually at the moment, no PSMA ligand is approved for clinical use in any country. However, in Europe and especially in Germany, we can use these non-approved agents within certain limitations. And that actually explains first why a lot of the data I'm going to present to you today is from Europe. Unfortunately, it also explains why most of the data is retrospective in nature. So they can perform their scans anyway. So the motivation to go through the financial and organizational burden of a prospective trial, especially in the beginning, has really been not that much. And we're definitely missing that data now, but eventually it will come in the next few years.
In the midst of it, did you explain what the difference between recurrent lens and prostate?
Oh, okay. Prostate is an antibody, and it's approved, but PSMA antibodies do have the problem that they have quite a high blood pool activity, and then this one is actually binds internally. So it's approved, but it's not very much in use, and it doesn't work that well. Same for the therapeutic ligands. So we are allowed to give them to patients who exhausted approved treatments, and then once again, that's what's happening. But then again, the data is retrospective, and there are no clear inclusion and exclusion criteria. So that makes it really hard to compare this data, as you'll see later on. So in a really simple way, what's PSMA PET imaging doing? Again, a picture from Heidelberg. It basically brings light and glow to things we otherwise might have not seen. However, if that's really good, we'll talk about that in a few minutes. What you can see here are the most frequently used PSMA inhibitors at the moment. They all have kind of a similar structure. So circled in green is the PSMA binding motif that goes to the active substrate recognition site. It's actually the same in every of the inhibitors. And then you have the radioactive compound bound to that via chelator or directly. And what you see on the right-hand side is the most commonly used gallium tracer, PSMA-11. So PSMA-11 is also called PSMA DKFZ, and it's also called PSMA HBE-DCC. So when you hear about that, it's always the same thing. On the far left-hand side, you basically have the therapeutic sibling of this inhibitor, PSMA 617 is usually chelator bound to lutetium. And the other three are basically the new kids on the block, the fluorine 18 tracers. And on the top you have the ones from Johns Hopkins, and the left one is the first generation tracer, which also had quite a high blood pool activity. So they started to develop a new one, and then on the right hand side you have the second generation, which is the leading candidate for them at the moment. And it's actually the one that's in use here at the BC Cancer Agency.
Wasn't the antibody you showed earlier called J591?
Yeah.
Which one is it there?
It's not there.
I think that's an important point to me. Antibody versus inhibitor. Why use it?
So inhibitors are small molecules compared to antibodies, and with that they have a lower blood pool activity, and they bind better to the PSMA.
What is blood pool?
Blood pool activity basically means, so when we perform the scan, then there is too much of the compound still in the blood, and that's not the thing with PSMA inhibitors like these ones.
What happens when signal?
Yeah.
What happens when the inhibitor binds to PSMA? Is it turn on?
Yeah. It is. Yeah. Okay. Let's go back to the tracers. The other one is the fluorine 18 tracer from Heidelberg. And now let's have a look at some data. First of all, why should we use the one or the other? Up to date, we cannot really answer that question. Gallium has been the one that's longer out there. However, fluorine 18 actually has some favorable characteristics. One of them is the half-life time. Gallium has a half-life of 68 minutes, which means a little bit less radiation burden. However, with fluorine, who has a half-life of 110 minutes, that basically allows shipping to satellite centers and even delayed imaging. Then there is another difference in the positron energy, which is a little bit less with 0.65 mega electron volt for fluorine. Theoretical, that allows for a higher resolution of imaging in the first practical experience. However, that didn't really matter that much. There's, however, one big benefit for fluorine 18, and that's the scalability. So gallium is produced by a generator, which means there is a defined capacity, whereas fluorine 18 is produced by a cyclotron, and that means that actually you can it can be produced as much as you need at the time of the examinations. So the most used tracer up to date is gallium, and the most assessed indication is disease recurrence. And what we are looking at here is data from a meta-analysis. There have been 12 studies included in patients who underwent a gallium PET scan for secondary staging, and they found an overall positivity of 76%. The positivity increased with the PSA category, so below 0.2 there was a positivity of 47%, between 0.2 and 1 of 58%, between 1 and 2 of 76%, and above 2 of 95%. You can see the corresponding forest blot and scatter plot for PSMA positivity regarding to PSA on the left-hand side. And yeah, I mean, it's quite clear that's great data, so we are seeing things much earlier than we would do with conventional imaging. However, of course, we do have to ask ourselves, is what we see really tumor? And that's something these 3 studies looked at, so there's not that much data out there for biochemical recurrence with histopathological validation. And they all have quite only a few patients, so 17 to 34. but they did find a high sensitivity with 91 to 100% on a per patient basis, and quite a high sensitivity also with 87 to 94 on a per lesion basis. So now we know we see things early. What we see is most likely tumor. The next question now, of course, is does it affect how we treat our patients? And
Did they correlate that with tumor grade, that histology study? I mean, you poorly differentiated tumors is it less sensitive?
no.
They're just as sensitive?
Yeah.
Where
So
you
the
differentiate tumors,
PSMA
it's higher.
expression goes up in tumors that, so the sensitivity actually goes up as well.
Okay. What was that described in those studies? No. It was a positive cancer or negative cancer, not necessarily.
Those studies are positive cancer and negative cancer. There is, as I know, one work out there that looked at the uptake in tumor grade, and it increases with the grade. Yeah. So yeah, coming back to if it does affect how we treat our patients, that's something this study looked at. It was performed in 150 patients. It's actually one of the few prospective studies I have for you today. And scans were performed, and then the physicians were asked if they changed their treatment because of the scan. And there was a response rate of 84%. 82% of the patients did have a positive PET scan, and there were major treatment modifications and 53% of the patients, which basically was most of the time a change from a systematic therapy like ADT to a form of targeted treatment, and then basically the other way around. So we know we see things early. We know it's most likely tumor what we see. We know it's affecting how we treat our patients. What we still don't know, and there's unfortunately no data out there, is if our patients really benefit from that. So is they have a better life quality? Do they have, is the prostate cancer specific mortality less with these changes? And I guess we have to wait for that data quite a long time, but that's what it's going to be ultimate about. So I already said in the beginning of this part, is it always good when there is light and glow? And that's something this study looked at. We actually performed not only PSMA PET CTs, but PSMA PET CT MRI. And what you can see here is the scan from a 66-year-old patient after radical prostatectomy for Gleason 8 prostate cancer, and the patient presented with biochemical recurrence of PSA 1.2. And you can see the PET CT, and then the CT only, and the PET MRI component, and you can see some bladder activity there, but I guess we all would agree that there's no sign of some local recurrence. However, if you now look at the MRI component only, you suddenly see this mass that definitely does not belong here. And in summary, in this study, they looked at 190 men with biochemical recurrence after radical prostatectomy, and 19 of these patients were diagnosed with local recurrence. However, only 10 of these were also positive within the PET component, and that's actually a statistic significantly mismatched. You can see another example of one of those scans on the left. So left bottom, there's again the MRI component, and you may have the feeling that there's something on the PET or on the CT, but you cannot clearly tell. So nice data, but of course hybrid PET CT MRIs are quite complicated and expensive examination that's only available in certain specialized centers. So we have to wait and see what the future brings for that examination. I also want to show you some of the fluorine.
They're lighting up, they're just indistinguishable from bladders.
Yes. That's the problem. That's the high urinary activity is the problem with gallium for accessing local recurrence.
What if you catheterize these patients?
It doesn't really change anything. So it has been done and it helps a little bit. But what you usually do is that you send the patient to the washroom before you do the scan. So they usually should have quite an empty bladder.
These patients all biopsy to confirm the conclusion of the scan? These 19 patients have local biopsies?
Most of them did, yeah. Not all, but most, yeah.
The correlation between the biopsy and the scan?
The MRI. So the local recurrence in the patients who underwent biopsy, the local recurrence on the MRI was confirmed as local recurrence.
Are you going to come back to
Am I?
MRI? Are you going to come back to PET MRI? Is that where this is going in the future? Is it better?
Well, it's definitely better in gallium for local recurrence. I think the timeline of when you do which examination has to be established, and there may be a place for PET CT MRI or for MRI only, but it's far too less data out there to really tell the best frequency of examinations. No.
I had a patient at the Heidelberg, and they did both and charged them for both.
Yeah, well, if you do both, you.
It's still cheaper than going to the US.
Okay.
I guess your point was this, is that the PSMA imaging has false negatives.
Yeah.
And so what would you estimate this is based on 19 patients, are you going to carry on with that, or will you give us a summary on what you think the false negative rate of PSMA is with gross disease?
The false negative with gross disease.
Because this is at least radiographically imageable disease.
Yeah. Well, there is no really a way to tell in this setting of local recurrence what the real false negative is, because you'll never know. So
here you're saying it's about 10 and 19. That seems pretty high. That you're looking at potentially with radiographically imageable disease. This data would suggest that close to 50% are negative. False negative.
well, I mean, it really depends on where the local recurrence is. And yes, gallium PSMA does have a problem with detecting things close to the bladder because there is a high activity in the urinary tract. So further down, further caudal, the problem is not that big. So I guess, yeah, of course, that's important that you have to look at the location of local recurrence. And of course, this is the data for local recurrence. So there's also the lymph nodes out there. So I also want to give you some data on the fluorine tracers. And this is some data for biochemical recurrence for the fluorine tracer from Johns Hopkins. 191 patients received either fluorine PET scan or a gallium PET scan. 62 of those patients received a fluorine PET scan, the other a gallium PET scan. And the results you can see in the picture A. And from that, the authors conclude that fluorine might be detect things earlier, has a higher positivity for low PSA values. However, you have to look at this data a little bit careful. A matching was only performed for Gleason score, not for other patient characteristics. And I guess it's too early to draw that conclusion. Histopathological validation was also only performed in a few patients. There's not really, the authors don't really say anything about what happened to the gallium patients with the histopathological validation, what to the fluor patients. They just state that there is a concordancy of 87%. So yeah, we have to look at that careful. data for the other fluorine tracer is even more limited. So far, this tracer has only been evaluated in 12 patients with biochemical recurrence. 3 of these patients actually did have a negative PET scan. They had a PSA below 0.5. However, on the other side, 1 of the patients had a positive scan with a PSA of 0.08. Most of the lymph nodes that lighted up in the PET were quite small, so smaller than what you would actually call tumor on conventional imaging. 2 patients underwent histopathological validation. 1 patient with biochemical recurrence after radiation therapy who received radical prostatectomy, and 1 patient with biochemical recurrence after radical prostatectomy, where a lymph node in the pelvis showed up, who received salvage lymphadenectomy. And there was a full concordance in these patients.
Claudia, which one of these do you have? This one or the last one?
The other one, the Hopkins. Yeah. So biochemical recurrence is not the only indication PSMA gets assessed for. The other indication is primary staging of prostate cancer. And I guess we all would agree that, especially for the local end, it fits to the local recurrence. So for the local detection of prostate cancer, of course, the MRI, with its now often proven high sensitivity and accuracy to detect the index lesion, plays a key role. However, if we then go to lymph node staging, there is, for the conventional imaging, it shows a pooled sensitivity of 42% for CT and of 39% for MRI. So the hopes here for PSMA PET CT MRI is that you may get all of that, a local staging and a screening for metastasis in one examination. Again, data from a meta-analysis that looked at 4 studies who examined the accuracy to delineate intraprostatic cancer lesions based on histopathology. So there was a pooled sensitivity of 70% and a pooled specificity of 84%. And yes, this is not as good as the MRI is, but I guess we can say that's quite reasonable. And then when we look at the accuracy for sampled pelvic lymph node metastasis for gallium PSMA PET CT, we do have a sensitivity of 61% and a specificity of 97%. And then again, this is not perfect, but it's definitely more than the conventional imaging. So here are just some examples for the fluorine tracers in primary staging. These are really only proof of principle studies in a few patients. That's a work that has been carried out in Canada, actually in London. They prospectively gave fluorinating to patients and that underwent PET-CT MRI and PET MRI. And what you can see here is the one patient where they correlated the MRI and the PET with the histopathology. And at least in this patient, it's a perfect match. But there's not really more out there. There's a little bit more out there on the accuracy for assessing pelvic lymph nodes. A study that has been done in 25 patients where 5 men who were positive out of 7 actually showed these lymph nodes. 2 men did not have lymph node metastasis on pathological evaluation. However, we do have to be a little bit careful with that because we do not know, was the PET wrong? Did the surgeon not find the lymph nodes? Or did the pathologist not find the metastasis? So that... That's actually what we have to ask ourselves. Nevertheless, for these few patients, they found a sensitivity of 67% per lymph node package, and you'll have to see what the future brings. For the other fluorine tracer for pelvic lymph node accuracy, there have been only 8 patients, quite a lot lymph nodes have been removed, 309 in this patient. That was actually done by Boris. And 19 of them had positive lymph nodes. And PSMA found 95% of those, and there were no false positive findings.
But from the clinical point of view, it's the specificity that is more important. Be able to tell, to avoid doing a lymph node dissection if it's negative. It's true to negative on the scan.
That's true. Yeah.
And if the sensitivity is low, you're going to do and it's a high risk to do the node dissection regardless.
Yeah, I agree with you. Local disease accuracy has been evaluated in 10 patients with the tracer. 9 of them also underwent MRI, and basically both imaging modalities did find the index lesion. However, both imaging modalities did show some lesions that could not be found on histopathological correlation, 3 for the PET CT and 4 for the MRI. And multifocality was also a little bit of a problem, but then again for both examinations, actually for both imaging modalities. So that basically brings me to the end of the imaging part. And I said before, it's not approved. There's not a lot of prospective data out there, but there's a lot going on. So gallium and both of the fluorine tracers are at the moment in prospective trials all over the world. And at the BC Cancer Agency, there's a fluorine 18 trial with the Johns Hopkins tracer, which basically is open for patients with biochemical recurrence. And there opens up a company-run trial, safety and efficacy trial for gallium, where basically the only inclusion criteria is that the patient needs to have prostate cancer. To summarize that, the mostly retrospective data for gallium shows a high sensitivity for assessing biochemical recurrence, even at low PSA levels, and also for staging primary prostate cancer. However, the high activity in the urinary tract causes limitations, especially for assessing local recurrence. PSMA PET CT MRI might help to overcome these limitations. The new fluorine labeled tracers have favorable characteristics and show promising first results. It's also expected for the new fluorine tracers that they have a little bit less urinary activity, so that may help with the limitations of gallium. And yeah, said very often today, we do need more data from large prospective trials. So let's now move on to the radioligand therapy part. The principle for PSMA radioligand therapy is actually exactly the same than for imaging. So we have the tumor with the transmembrane protein, and then we have the ligand that binds to the active substrate recognition site. But this time there is a more radioactive compound attached to the ligand. And so far there have been 3 compounds in clinical evaluation. One is iodine, the other one is lutetium, and the third is actinium. Iodine and lutetium are beta radiation emitters, and actinium is an alpha radiation emitter. And by that may be of importance. I'll tell you a little bit later on. Saying one other thing, whenever there's a radioactive decay next to the radiation we want in this case, we also do have some gamma radiation. Gamma radiation is a deep penetrating radiation that damages the tissue and causes a lot of side effects. So this is a radiation we do not want. And iodine actually has quite a lot of gamma radiation, which was the reason why at least Heidelberg stopped to use it. And lutetium has a little bit less. Nevertheless, let's have a quick look at the iodine data to complete that. So between 2011 and 2013, this radioactive compound was given to 36 patients with progressive metastatic castration-resistant prostate cancer. All of them, of course, received at least 1 cycle. 2 patients were lost for follow-up, 23 received a second therapy, and 3 a third therapy. And what you can see at the bottom are the scans from one of the patients who received 3 therapies. So while the first therapy cycle did actually show some improvement, there was only little improvement after the second and basically no improvement after the third cycle. This slide summarizes these results. The median overall survival of this patient was 17 months. They looked again at the data in 2016, and there actually 4 of the patients have been still alive. After the first cycle, 71% presented with a PSA decline of over 50%, and that became less to basically no response with the second and the third cycle. And then the other thing we want to look at is the toxicity. So already after the first cycle, there was a grade 3 to 4 toxicity of 11%. Usually that's some kind of bone marrow depression, so anemia or thrombocytopenia. Or leukopenia. Another important thing relates to the physiological distribution of PSMA, so it's often xerostomia and nausea, which the patient really suffer from. So when we then look at the second and third cycle, there was quite a lot grade 3 and 4 toxicity, and that's not that tolerable for our patients. One other thing is that with this high gamma radiation, iodine patients actually needed to stay in the hospital for 7 days, whereas lutetium patients need to stay in the hospital for 2 days. And lutetium is used in quite a few German nuclear medicine centers at the moment, and they try to retrospectively pull that data together and have a look at it. So this is data from 145 patients from 12 different centers. You cannot really call it inclusion criteria, but all of these patients were progressive under next generation ADT or under first or second line chemotherapy, or they were not eligible for chemotherapy. Some of them even received radium therapy before they received lutetium therapy. They needed to have a positive PET scan, and of course they received at least 1 cycle of lutetium PSMA. 76 of those patients received 2 cycles, 25 3, and 3 4 cycles. What you can see here is the site of metastasis. So you can see that next to bone and lymph node metastasis, quite a few of these patients also had visceral metastasis, and then you can see the previous therapy, or at least a summary, and the previous therapies were of course quite extensive. Some of the patients even already went to some kind of experimental treatment. Out of these 145 patients, there were serial PSA levels available for 99 patients, and in those 99 patients, response rate for a PSA of over 50% was 45%, most of them already after the first cycle. Follow-up PSMA PET imaging was available in only 47%. Out of those, 2% had a complete response. Saying that, they were of course not cured. That was a temporary complete response. So they did develop further metastasis again. 45 had a partial response, 28 a stable disease, and 25 a progressive
Let's clarify
disease.
too quickly. The 617, that's the small molecule that binds to PSMA? Like, what's the 617?
Yeah, yeah. So that's the tracer that binds on the one side via the chelator, the lutetium, and on the other side it goes to the PSMA, and then the whole pack gets into the prostate cell, and then it emits radiation there.
And there's evidence that that whole package is internalized?
Yeah.
From animal studies or humans? Or how do you prove that it's internalized?
To be honest, like with the clear process, how that was demonstrated, I cannot tell you that at the moment, but it has been demonstrated that, in fact, it is like that. So,
Can you image with lutetium as well? Or do we have to then do a gallium image?
well, you can catch the radiation, so that does give some kind of image, but there's no point in using lutetium as an imaging compound because the radiation is damaging everything. So yeah, in theory you could do that, but there's no point in using it for imaging. Let's have a look at the side effects of lutetium. So again, looking at bone marrow toxicity, there was a grade 3 to 4 toxicity in 18 patients, which is 12%. And when you look, if you can even read them, when you look at this data, the numbers actually are a little bit confusing. When you count it together, it's not 18, but that's because some of the patients had leukopenia and anemia. So they counted here twice. And then you say, okay, that's 12%, showing us the iodine data. There was 11% for the first cycle, and you said here we have less gamma radiation. So what's going on? That's really the problem with the data, because that's the data for all of the cycles that have been conducted, and there's no substratification in this work for the single cycles. Other important side effects, as I said before, are xerostomia, nausea, and of course renal failure, as this is also where PSMA is expressed. And there the data is actually quite good, so there was no grade 3 or 4 toxicity, and only some quite reasonable. I just read it out for you. So xerostomia was 9% and nausea 6% and renal failure 12%, so quite reasonable side effects. So what's now the rationale to move even beyond lutetium and go to actinium? Of course, these are agents that are used in patients who exhausted approved treatments, but when we think of something that's maybe used earlier on in clinic or maybe even should cure our patients, then we definitely need something that also targets small metastases. And here we actually find the limitations of beta radiation. Beta radiation has a millimeter range, and that basically delivers insufficient amounts of radiation to millimeter-sized tumors, because most of the energy basically is then beyond the boundaries of the tumor. Opposed to that, alpha radiation does have a micrometer range, and with that it can target millimeter-sized tumors. What you can see on the left is a theoretical calculation for that, and you can see that the beta-emitting lutetium does have some problems here in the smaller sized lesions. And yeah, that's actually the rationale to move on with actinium, and so far actinium has been given to 14 patients. Again, all of them exhausted approved treatments. So what you can see on the bottom here is a waterfall plot for the PSA response. There have been different dose levels of actinium, however, not really in a dose-finding manner like in a prospective trial, but the nuclear medicine physicians just decided on which dose to give which patients based on their clinical appearance. Nevertheless, in the patient with the 50 kilobecquerel, there was not really a PSA response, and in the patients with a dosage above or at 100 kilobecquerel, there was a PSA response which was not clearly dose dependent. What you can see on the left are the scans of one of the patients who received actinium. This was actually a patient that did not have PSA in the beginning of, so metastasis was diagnosed by imaging, and you can see quite amazing, again, only temporarily limited, that nearly all of the metastasis is gone. To summarize that, so I already said PSA response above 100 kilobecquerel per kilogram body weight, but then with 150 and 200 the side effects, mostly xerostomia. One patient had a severe xerophthalmia as well, were too high, so the dosage they want to move on with is the 100 kilobecquerel. And yeah, I guess it's exciting to see what comes out of that. So there are no radioligand therapies trials going on in Canada as far as I know. However, there are some in the US with lutetium, and yeah, we'll see what comes. So to summarize that part, radioligand therapy with PSMA labeled beta or alpha emitters has been shown to have reasonable side effects and induce PSA or imaging response in patients with castration-resistant prostate cancer who exhausted approved treatment. Long-term effects and as well as the optimal therapeutic timeline have yet to be investigated, of course. And yeah, that's it. So thank you very much for your attention.